All right. Welcome to my live stream. Thank you for joining. My name is Dr. Richard Hilsden, and this is my first live stream on night skills. Dr. Tommy Chan will be joining me shortly. And really, I'm just hoping to explore what live streaming has for us on YouTube and really try to connect with people on a more personal basis. I think that's definitely possible with live streaming for sure. I think what we're going to do is we're going to talk about a number of topics today. I'm really curious to see what Tommy has to say, Dr. Tommy Chan has to say about education in the healthcare system, how his training went as a neurologist, as well as sort of the experience of training overseas as well. So I'm going to pop in and add Tommy to the screen. Tommy Chan, Dr. Chan, how are you, my man?
Good evening, Dr. Hilsden. How are you?
I'm going to make sure my headphones are on so I can hear you a bit better. All right. Classic. This is called what they call is this is called struggle streaming when you're in the middle of a stream still figuring out the details.
Yeah. Can you hear me okay?
All right. All right. And as I'm doing this, like I'm having like a definite computer troubles. It's amazing how it always happens. The moment you think something's gonna work and then immediately fail on my end. But I think you can hear me all right, Tommy. Is that right? Give me a thumbs up.
Yeah, I can hear you.
Yeah, no, I think you're fine. I'm having like a strange problem with my sound on my end. So I'm gonna keep working on it, and we'll get the conversation going momentarily. Again, like I said, they call this aspect struggle streaming. But yeah, hilarious. They have no audio devices at all for outputs, which is funny, just out of the blue. All right, can you hear me? Can I hear you now? Let's see if I can hear you now, Tommy.
Can you hear me?
Yeah, I can hear you. I can hear
Great.
you.
How are you, man?
So at some point, I'm gonna sort out my why my Bluetooth isn't working, and then it'll be so much better. But anyway, how's your night going, Tommy?
Great. Caught them on paperwork. Never stop working, right? But
Yeah, well, that's the thing with being a doctor is that the job doesn't end at the end of the day for sure, does it?
no. And how about you? How was your day?
Very good, very good. So, basically spent the day just like you, doing a little bit of work, but also trying to relax, get some entertainment, spend some time on social media. One thing that I was working on though, when it came to my social media, is this idea of trying to find a work-life balance. And I don't know how you find it. This is your first year in practice. Like, are you finding yourself like so focused on work, or are you, finding a way to like enjoy the downtime as well?
Yeah, I think that's a good question. Like we always want to find the perfect work-life balance or work hard, play hard kind of mentality. I think it's obviously difficult during COVID time, where like we can't do a lot of traveling or spend time with family and friends. But I guess uh, you start to develop a routine to when you're off work to try to keep yourself sane, right? I think that's what I'm trying to do. And like what I was alluding to before, like work never really stops. So sometimes it's just important to like put your just close your email, your browser for a
Yeah,
couple hours,
yeah.
or else you get too paranoid and stuff. So, but that's kind of the way I'm still navigating through finding the sweet spot. But again, when COVID time ends, whenever that may be, you ask me the same question, might be a different answer, right?
Well, I know that when, like right now, for anybody who's watching, we're right in the middle of a bit of a lockdown in Ontario. And so restaurants are closed, the gym is closed. I know for you and me too, maybe a little less, I'm a little less much of a gym monkey as you are, but even for me, just not being able to get out to the gym on a daily basis, like you feel it. So I'm definitely jealous of people who are maybe in other jurisdictions that don't have the same restrictions.
Yeah, I think it's tough when you look at social media, right? Like a lot of people in like Asia, Australia, United States, even though like COVID's happening everywhere, but like they're not living in a hard lockdown situation. So you see them like doing like social activities, you're like, well, we're in the -20.
It's hilarious. It's like you watch it, you're like, I just want to be where the people are.
I know.
But it's a great point because we have a pretty tight friend group, and right now, again, my hospital, we both work in the same place, but there's a huge outbreak on the surgical floor that I work on, and it's hard. Like even just spending time with friends that you normally would, it feels a little bit. I don't know, does it feel wrong or do we feel guilty that we're just, we're definitely not breaking a rule, but this idea that what if we get sick, we won't be there to care for our patients.
Yeah, I think actually, like we had an outbreak before the surgical floor. Like it was on the neurology floor first, and
Oh, it
then
started with you guys.
yeah,
Thank you.
yeah, and then
Thank
but
you,
then
Tommy. Appreciate it.
yeah,
Wash your
yeah,
hands, man.
yeah. But the threshold is quite low, right? Like you got a couple patients with the case. It's an outbreak, right? And then by the way, I where's my old fashioned? Like I need
Yeah,
a.
well,
Can
you got
you
to
send
make one
me
yourself. Cheers, though. Cheers.
I got some water right here, but
Yeah, that fits.
now I was saying is I think you're right. Like especially that we're subspecialists in some ways, where like if we're sick or if we have to isolate, it's going to be a huge burden for our colleagues, right? And I'm sure that you personally and I personally have to cover for other people, and you hear them from the nursing staff situation is a big issue in Ontario. And then it's the same case for the physician, but obviously our number is a little bit lower, so our voice is not as loud, but it exists in
Yeah,
healthcare.
yeah, yeah. No, you're absolutely right. And I had to cover over the holidays for some people who got sick with COVID. And actually, when I got sick in the summer, you might remember I had some people covering for me as well. And so it was nice to be able to kind of pay it back, help someone else out who helped me out. So that was nice. But there is a burden. It was like a way heavier holiday time for me than I expected because I had to cover someone who was sick. So it's a real problem, and it definitely affects people's lives. And the problem for me is I just don't feel like there's an end to this thing. It's like at some point we're gonna have to get used to living with a pandemic, with a virus, or at least figured a way to adapt. And I don't know. The moment we see some hope, all of a sudden we get it kind of pulled away, and we're like, no, we're stuck in lockdown again.
You know, it's interesting you brought that up because I was just reading. I actually searched on Google today, just like when is this going to end, right? Like, and
You just literally Googled, when
I
is it
just
going to end?
like when is this going to end, right? You surprised that no matter what questions you type, like people have asked that on Google, and somebody probably answered that. Like it actually resembles very similar to the Spanish flu back in the 1918.
Okay.
They were hit with 4 waves as well. I was reading it,
Mm,
and obviously a lot of people died. Medicine was not as advanced as where we are today, and they actually did the same thing. Apparently, they were going through lockdowns, and people were inside the house wearing covers and like homemade masks. They
really?
were doing exactly the same thing, like almost 100 years ago. It's
Yeah, they didn't
crazy.
have PCR tests or anything like that either,
It's
so
crazy.
there's
A
no
lot
way
of
to really know.
yeah, and
Well,
then
that's one of the challenges here. If you had a sniffle, is it COVID or is it something else?
sorry.
I said, even if you get a sniffle, you're asking yourself, is it COVID or something else? I made the joke the other day. I think COVID is the one virus to rule them all. As far as I know, nobody's been sick with anything else. If you get sick, you're basically assuming it's the virus.
I know, because especially in wintertime, we're like you're gonna get a little sniffle, a little cough, a little sore throat. I had this little dry cough that for no reason, like on and off for a few days, and then I did like 10 PCR tests that were all negative, and so I'm like, well, imagine like that's what everybody's going through right now, but without the PCR access, right? Like, that's why people are having shortage to lining up for the rapid tests. I'm sure you see that on the news,
Yeah.
and then let alone the rapid test, the PCR test is it's so delayed and you can't even find an appointment. So people will like just because they have maybe a soft one symptom, they're isolating, and it really disrupt the whole world basically.
So it made me think while you're talking, Do you think if you could reflect on like this year, was it a good time to start practice? Because you really just started practice in 2020 as a headache neurologist. Do you think like starting a practice in the pandemic is a great idea, or is it like a terrible time?
I
Are
actually
you
think
lucky or
I think it's a good question. I was looking because like we're like a couple of weeks after New Year's, and usually by New Year's I reflect on the past year, and like what you say, I just kind of like entering my second year of my academic practice, and I look back and I felt that it was actually a blessing in disguise, because
Mhm.
as you probably know, uh, working in the bigger hospital, there's a lot of politics and there are a lot of people that you interact with. But
Yep,
by working in the pandemic, obviously a lot of things are virtual. It allows you to kind of ease into it in some ways, and it
for
also
sure,
creates a
for
lot of
sure.
flexibility on your practice, and also because of the technology that we need to be comfortable with, more likely the junior consultants are a little
Mhm.
bit more tech savvy. So like
True. That's
I'm
interesting.
pretty good with using the computer, the
Right.
phone, or using resources online, using media, using different
Yeah.
things to for medical education. And I think that for me it worked out, especially in my specialty. It's a lot of times the clinical assessment, it's the neurological exam is normal, so it's very
Okay.
different than you as a trauma surgeon who like you have to physically be there to operate and do something and assess.
Now, look, okay, so get this straight. I mean, I'm thinking about when I was a med student and I like studied neurology. I mean, the neurological exam is complicated. You got to do reflexes. You got to do like I don't know, like clonus exams and all these things. Like you
Yeah.
need to have your hands on the patient. How are you
No,
going to
no,
localize the lesion, Tommy? How are you going to localize the lesion?
you know what? That's they actually have a lot of virtual sessions on how to do a neurological assessment over the video, and you'd be
Really?
surprised that a lot of, for example, like movement disorder, like it's that the diagnosis is made by watching videos and observation. I'm sure medical students or people have seen people with
Yeah.
tremor,
Yeah.
myoclonus, all these movements. You're right though. If somebody is having a very subtle neurological findings, yes, you might
Mhm.
miss it because you're doing this virtually. But as you know, we are quite advanced with our technology now that like, hey, getting that's why they're imaging. I'm sure cardiologists can also relate to that. How
Yep.
important is it to auscultate all four areas now when
Right.
most people end up getting an echo, right? So I think that's a reality of the situation, and I guess it's a debate. Well, is that a good utilization of resources? But I think nowadays we tend to investigate anyway, I would say. So like you're able to, I won't say compromise, but like if your exam is not 100%, you at least
Yeah.
back up investigations.
So pretty much everyone gets an MRI in your case. Is that
Hey,
basically it?
no, no,
Maybe.
no, no. There, you know what? There's that that not feeling. There's the instinct that you know when people's history, and I think the history is often forgotten how important this. Whoever's listening, if they're medical students out there or generalists, like you have probably seen the neurological assessment, like the history taking. Like it's basically a psychiatric history, and by that history alone, 80 to 90% of the times you already know what you're dealing with, right?
Yeah.
And then that
Yeah.
exam will help you confirm it. So I would not say that I would investigate. If everybody comes to me with headache, then like I'm telling you, all the patients want an MRI, like
Yeah.
100%.
It's funny. They're all afraid it's a brain tumor, I'm sure.
Oh, everybody, 100%.
And what it's like, I mean, I'm sure maybe you've never missed anything, but I've missed lots of things in my practice over the years. Uh, in your field, like how do you prevent yourself from missing the big one? And I guess and maybe the question I'd like to ask is like in neurology, what are the big ones? I mean, the big one's a stroke probably. But then I'm sure like a brain tumor would be another one. Are there any other like big, big diseases in neurology that you just can't miss?
Yeah, so like stroke people are probably quite educated with like the fast, right? Like you just react to it, you call 911, and basically everybody knows kind of symptoms to watch out for, and they get brought into an emergency room. But like in my practice, for example, it's like we have mnemonics that we run through, making sure we run through these history questions that these are not like, for example, give you there's we have a mnemonic called SNOOP, like
Okay.
SNOOP. It stands
Okay.
for systemic symptoms, neurological, focal neurological symptoms, acute onsets, which stands for O, and then also O stands for the other O stands for old age. Anyone presents with a new headache after the age of 50. And then P
Okay.
stands for pregnancy, postural, papilledema, and progression. So if you take the history and you gather there's some red flags along those lines, then yeah, you probably want to investigate them. And I always, at the end of my assessment, say, hey, if you feel like this is a little bit different, you go to the emergency room and they'll scan you anyway. But let's say if
Yeah.
something's going on for 20 years, the symptoms have not changed for 20 years.
Yeah.
Even
It's
if you have
unlikely to be anything bad.
even if you have a brain tumor, I always tell them like there's about 3% chance that people might find an incidental finding in MRI. That brain tumor was going to still be incidental, sitting there and doing nothing for the rest of your life. It's always that debate, though, right? Then people sometimes want to know so that they could monitor it, or
Yeah, but the problem with that truly, and as a surgeon, it's like you can get sometimes a incidental finding that you have to act on, like it's like a requirement. So in my world, I mean, like you could have a little lesion in the pancreas or something like that. It could be pancreatic cancer, but it could be something else, like an IPMN that's not that bad. You almost feel like you have to act on it, right? It's like, what if I leave it alone? It could be something terrible, and then you end up doing interventions on people that actually don't benefit from it. Breast cancer is another example of that. You might find a small little DCIS or something like that, do surgery on it. Are you really helping that patient? Because not everybody with DCIS is going to go on to have breast cancer. Like in fact, most won't. And yet you're compelled to act on it and give them radiation and all these kind of things. So there are times when you can end up, by investigating someone, actually cause harm. You're finding an abnormality, but now you're forced to act on something that wouldn't have had a negative impact, right? It's a really interesting thing. We're trying to sort out survival and how what we do as a doctor, whether it benefits people or not.
Yeah, I think it's different if things are happening in your head. Brain surgery, like the risk and benefit
So
discussion,
high, so
probably
high.
a little bit different than let's say abdominal surgery. But you know what? Like I think it's never right or wrong answer. I think that like it's everything is very individualized. End of the day, it's a conversation you have with your patient about like, hey, listen, this is your situation, this is your story. Like you're going to be different than the previous or the next patient I see. And then, like, end of the day, if both of you are on the same page, like, even if you miss something now, like, but if something were to change, like, subsequently, they're going to be able to have that investigation done anyway. So, a lot of people think that medicine it's one point in time. I think a lot of medical trainees feel like they're so used to doing an OSCE or a station or assessment. And like, this is done. If I miss this, I'm done. But no, in real practice, it's that you see them once and then you follow them up, right? Like I also
Absolutely.
follow them. So to follow the question previously, if I missed something first assessment, and I missed things, I would admit as
Yep.
well.
Yeah,
But
we all do.
I was like, wait a second, like the treatment's not working, things not going well, things have changed. Well, you have another chance to investigate them, but you always tell them, hey, if things were to change rapidly, go to the emergency room. So I think that's kind of
Absolutely.
one thing about the continuity of care that in medicine that I think is often underappreciated
It
or
should be like part of training to say, hey, if you're not sure, bring the patient back.
yeah.
Give yourself another chance to take a look at this, and give the patient another chance to even think about their symptoms or what's going on, or you can see how things change over time. That can be a huge aid. And I imagine in headache, that's probably especially true. I can remember that when I was applying to my family medicine residency, I did an interview in Toronto, and literally the question that was asked, and this is like more than a decade ago now, the family doctor asked me, said, Dr. Hilsden, or future Dr. Hilsden, every headache could be a brain tumor, right? How do you sort that out with the patient in front of you, knowing that there's a possibility that every headache could be a brain tumor? You can't investigate everyone. And I actually said that. I said, I understand the concept, and really what he was getting at was this cornerstone feature of family medicine. It's where you have that relationship with the patient and you see how they do over time. It's a little harder as a subspecialist, but I can imagine, or at least I still try to use that concept as a tool in my own diagnosis. Multiple
Yeah.
patients come into general surgery. I'm like, you know what? I'm not sure what's going on. Let's do some basic stuff, basic investigations, see what the results of those are, and let's see how you're doing in 1 month or 3 months time, depending on the situation.
Yeah, Like I think that's 100% correct, right? Especially as a family doctor, like how many things that you, how many different cases you're gonna see throughout the day, and you're not gonna like get the brain scan on everybody who comes in with the with the complaint of a headache. They probably see like hundreds of people's over a week, right? So like, and I think that the answer is correct, and that's why you passed.
Yeah, I did. I didn't actually go to Toronto. They would have accepted me, I'm sure, but I ended up matching to McMaster, which is what I wanted. But this is actually an interesting question too, because like headache's such an interesting thing because so many patients struggle and suffer with like chronic migraine and it's years and it's debilitating and it affects their ability to perform their work and it affects can impact their romantic lives. I mean, so many ways like chronic headache can be awful. And yet I wonder like how many referrals do you get as a headache specialist are really not that useful in the end, or you're happy to kind of see anyone if they have a chronic headache. Look, you're the guy, or is it a bit of nihilism saying, well, there's only a small number of headaches I can treat, and there's this whole like iceberg under the water of headaches that just aren't going to get better no matter what I do.
Yeah, well, that's a good question. It took me like 2 hours today. I was in the office to triage the referrals. That just tells you how many referrals I get. And
Yeah, no doubt. I was gonna say.
I think that like that's part of the training comes in, right? You can discern to know that what are something that you can offer them, and obviously in triage, bring people in. First of all, you have to decide you're going to see them or not see them.
Right.
Can they be managed by someone else or their general practitioner? And then after you do decide to see them, you're going to triage them based on urgency of their, based on the details provided from the referral. And sometimes I do already make suggestion and over the response. And so let's say either even get a scan before, for example, let's say if they're concerned that somebody has a high intracranial pressure headache, for example.
Mm-hmm, mm-hmm.
And I'm like, please get an MRI to root out the venous clot and things like that. And I think that's like something, or like that's a brain tumor, for example, like could do that.
Yeah. Yeah.
So I think sometimes like rather than like waiting on the wait list, sometimes then you get an investigation and then bring them in at the same time. So there are different channels that patients go through. Again, I think that is one thing that most people probably not aware of until they become like they start working independently. That like it's not just about somebody sends you a patient, am I going to see it or I'm not going to see it? And it's not as simple as that, right? There's different ways that you can manage it, triage it, and
sure.
I think especially for chronic disorder, like I think for something acute, which is similar in your case, I guess for if it's trauma, then if it's a stroke, well there's no triage.
Those are different. Yeah, you're responsible for that case.
Yeah.
So, like, how many referrals would you reject on average? Because I mean, for me, I struggle. Again, I do general surgery and trauma, as you know, but I have a hard time saying no to anything that's even closely within my scope.
Yeah. Initially, I was probably accept most of them, I have to say. But over time, I realized that how prevalent headache is, especially I see a lot of migraine patient, and so I would say right now, after a year of practice, it's probably about like 50-50 that I have to, I don't want to say reject. I would probably use the word saying I would probably ask them, I will provide them with resources, other people who may be able to have a shorter wait list. Obviously, these are people who knows what they're doing. Sometimes because we work in southwestern Ontario, that we cover a pretty big area.
We do, yeah.
As a tertiary center. So sometimes if let's say they have heard of your name and you've done something nationally or internationally, they come across something they've done, interviews, whatever that may be, or your publication, they might even send you through it from Toronto or McMaster or Cambridge or Windsor. But there are people who are there who are neurologists who have an interest with headache. They might not be a headache neurologist, but as a neurologist, you should have some knowledge on management. And so I would, in those cases, then like I will ask them to refer to those people locally. So I think that kind of helps the situation. But like after 1 year, I think my wait list right now is probably at least 6 months to 12 months now already. It is
Wow.
a little crazy.
Wow. I mean, I definitely try not to have that long a wait list in general surgery, but um, and really how I avoid it is I do uh, redirect patients that I'm not likely to operate on to someone else or something else. Oh, this is more appropriate for gastroenterology or maybe another specialty, for
Exactly.
example. I'm
Exactly.
gonna just pull this up. I don't know, Tommy, can you see this here? We just got a question here from Wally J, who said, "Good evening, docs. I'm a student at a U.S. med school, and I'm wondering if there are any symptomatic presentations of COVID that you've seen unique to your area of specialty, neurology or general surgery." So, I mean, I'll give you an opportunity, Tommy, to crack at that question. And I've got one or two cases that I could tell you. Maybe not of symptomatic, but I have a COVID story that I think
Yeah,
I'll
yeah,
share.
yeah. That's a good question. Well, I like you must be you must like to fish.
Yeah, you're a fisherman too, eh, Tommy?
I'm actually was appointed as the headache doctors for the COVID clinic. So like I get referrals from the COVID clinic to manage people's headaches. So great question. So I will probably answer specifically with headache because headache is the most common presentation basically of any neurological issue. Two things. One of them is that people who after they get COVID could develop something called like a new daily persistent headache, meaning that a headache that's 24/7 unremitting, which in theory, just trying to long story short, people can have this headache that may mimics tension type headache, migraine, and the mechanism behind it is like a cytokine storm. Like you just like you're
Okay. Okay.
a huge inflammation in the body. Sometimes people get better, sometimes people don't, but then you just kind of manage it symptomatically. Secondly, is that venous sinus clots. So a lot of times that people can with COVID and the vaccine. Sometimes you might have heard of that in the news too.
Yeah. Yeah,
When
that's
they
right.
were doing it a little bit with the AstraZeneca at one point
Was it
was brought.
AstraZeneca? I was trying to think, or was
Yeah,
it the
it
Johnson and
was
Johnson that was the
brought
one
up.
that was
So
causing that problem?
yeah, and then the people getting vaccine could also develop a new daily persistent headache or have a venous sinus clot. So I have to say, from all the patients that come to me, if they develop a new type of headache from COVID or vaccine, I would get an MRI of the head and getting a venogram, which is looking at the vein as well. So I think uh, I'll hand the ball back to you, Rich, because
Yeah, great question. Great question. So for me, there's not really like an obvious like trauma relationship with COVID, as you can imagine, and that's what I do for the most part. But there are two things. First of all, abdominal pain is probably one of the top list symptoms when it comes to COVID, and every patient who general surgery is operating on has abdominal pain. I have not been fooled. It's possible to take someone to the operating room because they have severe abdominal pain, and it proves that there's nothing going on, and maybe it was COVID that caused it. And I could say once or twice we did have some negative surgeries. We thought, oh, maybe it was this COVID, but it didn't actually turn out to be that way. But my absolute favorite COVID case related to trauma was a guy who came into the hospital. He was stabbed in the neck and was like bleeding out of his neck, and he didn't come in by ambulance. No, he went in through the wrong entrance of the hospital. He didn't go to the emerge. He went in through some random entrance. And at our hospital, like many hospitals, there's COVID screeners that are supposed to like check you in to make sure that you can enter the hospital. They're not necessarily even medically trained. They could be a security guard or something working at the COVID screening center. This guy like walks in through the COVID screening area. He's like spewing blood out of his neck. And they're losing their mind. They call security and everything. And they end up calling a code blue, resuscitating him like at the door of the hospital, and then dragging him to the emergency department. And so we end up operating on him. We had to do a surgical airway and everything. And in the end, he was fine. But it turned out he was COVID positive. And so many people in the hospital got exposed to COVID because he came in and had this like obvious like terrible wound, and people were just walking down the hall at the time. They weren't like prepared for this situation. Nobody at that part of the hospital was ready to deal with an emergency. It was like people just don't go into the wrong entrance usually with an emergency. They usually go to the emergency department. And so anyway, a huge number of people were exposed. People had to take time off work because they had to isolate after this like high risk exposure for this guy bleeding out the neck. And so it was a little bit of a sort of a a concept that was anyway.
That's like something you see on TV, like an episode of House or something, right? Like
It
there's
was, and yeah, it was funny because one of the surgeons, who's a trauma surgeon, ended up like just happening to like it happened like outside of his office and was at the hospital at the time and was taking care of him. He's like, he called me, he's like, Rich, you're on call for trauma. Like, I'm dealing with this thing. Come on in. So it was pretty funny. I do want to actually, there's another comment here in the chat that I'd be interested in sharing with you, Tommy. What do you think about this? So this is a response to your comment earlier about having a 6 month to a year wait list to see a headache doctor. And then they say this concept of a wait list is unfathomable to me. Socialized medicine sucks. Now, the reason why I'm bringing this to your attention more than me is that you've had the opportunity to work in 3 healthcare systems. You've worked in Canada, of course, Australia, and the US. So you're better than anyone to sort of, describe how the different systems work and whether they're good or not.
Yeah, I think it's there's no perfect healthcare system. I think that's the first point. And I was trained in Australia, where they have a dual healthcare system, public and private. And then US, I was there for a lot more rotations and my fellowship training, and in the private hospital at Stanford, and so like. But one thing I would say though is that in a perfect world, then you will have more of us. Not only we have more of us, then you also have more hospitals, and then so that's mean that comes from resources. So it all trickles down. So okay, if there's private hospitals, meaning that there are going to be more doctors they can train as well. So if you just look at the numbers of medical trainees graduate, I'll give you an example. About 40 neurologists graduate in the whole country of Canada in 1 year. Okay, 40.
40, that's crazy.
In the whole country. In US alone, in New York City alone, okay, New York, 1 year is about 80.
Wow. One city trains as many people as Canada. Now that says a lot, because recognize Canada is a country of about 40 million people. New York City, 10 million maybe? What do you think?
I think so. I may be wrong that,
Well,
but
per capita, it's not. So we train 40, they train 80, and we're 4 times as big as they are, let's say. So, you do the math there. That's 8 times more neurologists per capita.
Yeah, that's about right. Like there are like the places where, for example, if you want to get a fellowship training position, you realize there are about 30 different centers in the US that allows you to become a headache neurologist, for example. In Canada, there might be 2 places. So like it's all a number thing at the end of the day, right? Like I think if you have more resources, more hospitals, then obviously then the wait list will be shorter, because there's more people kind of doing assessment and trained and capable of assessing that. And I think for example, Australia, I was saying that it's a good balance between the two is because it is exactly the system between US and Canada. Like the example of the New York and the whole country of Canada, Australia is like exactly something in the middle, right? They
halfway between, you think?
Halfway between, and then people who work in the private sector also have to provide a service in the public sector. And then
how do they enforce that?
It's a contract that you sign when you do medical training. I'll give you an example of why a dual system. I guess this could be another like 5 hours discussion. I was a medical student, and I like to play basketball, as you can see my painting back here.
Hey man.
I sprained my ankle, and I'm like, oh my goodness, I don't know what happened, but I had good insurance, right? Like through med school, and I was like, okay, how long is the wait to go to the public hospital? Say 2 weeks for an MRI of my ankle. I'm like, oh, that's not too long. In Canada, usually that's like 6 to 9 months because it's not an emergency. And then I said, oh, what about the private? I was like, right now. I'm like, wait a second, like I could get this done right now. Like that was so foreign to me, right? As a Canadian.
Yeah.
I'm like, okay, so I had good insurance. I had to pay out of pocket maybe $120 copay, but because of that system that allows me to choose privately, the wait list in the public sector is much shorter. So
interesting. So the public system benefits from a strong private system in Australia.
Exactly. So I think that sometimes people say that, oh, healthcare should not be only to the wealthy and rich. I don't think it's as simple as that statement alone. Okay. You have to, like that example of me spraining my ankle and getting an MRI scan tells you a little bit about the sweet spot between the public and private sector.
Yeah.
But again, Happy to discuss more about that with
Golden
golden.
foot cheese, golden goat foot cheese. So yeah,
Yeah.
I'm gonna just weigh in here. I mean, I try not to get too political at all.
Yeah.
The way I like to think of this issue is how are the people who are at the bottom treated? That's what I'm always concerned about. What about the people who are at the lowest socioeconomic group? How are they treated by the system? Because that's the people that need it the most. And so one of the challenges with a private system or the American system is absolutely you can get MRIs, X-rays, surgery whenever you want if you've got the money to pay for it.
Mhm.
But what about the people who don't have health insurance? How well are they treated? Now, I actually do suspect in some ways they may have some better wait lists than we do in Canada for some things, but they're not getting knee replacements. They're not getting robotic inguinal hernia surgery. Those are that's going to the wealthy few. And maybe they're not getting in to see a headache neurologist at all. They have to have their primary care doctor. There's no opportunity for someone without insurance, maybe in the US system, to see a headache neurologist. You know better than me, but that's sort of my feeling. And at least with the Canadian system, yes, you have to wait to see Dr. Jami Chen, but anybody can see you, whether you're me or someone who doesn't have financial means. Am I right
Yeah,
to say that? Or
I think that's a good point, right? In the U.S. where they have to Medicaid, right? If you make less than I think 30 something thousand dollars a year off American dollars, then like they have insurance to cover on selected hospitals. But like then the follow up question is what is the quality of care you get
yeah,
in
exactly.
that system, right? And you would say most of the well published academic doctors are mostly working at big centers that are more private based. It's true because, again, that's a separate discussion. They have more resources, research funding to feed
Yep.
into their publications and getting them to become more publishable and famous, and also boost the name for the hospital as well, right? The department. So again, it's like a cycle of I don't know. I think in Canada, you're right though. That's a very good point. Like anybody could come see me. Anybody. Like I would not say I would never reject a referral because somebody it's not making a certain amount of dollars, have insurance or not, on disability or not, or no. Like that is never gonna be the reason of seeing this patient later or rejection. Never.
Yeah, I think that's important. Do you think that happens in the US? I mean, again, I'm going to show another comment here. This is again
Yeah.
Golden Goat Foot Cheese. I love the name. Basically saying ERs can treat anyone who walks through the door. They have to. There's like a mandate in the US. I think you would understand this better. Maybe you could
Yeah.
explain to me
Yeah.
a little bit that rule, as well as Medicaid. You did mention that before. People who have income, you said under 30,000 qualify for Medicaid. Uh, they're saying, what's the difference? And again, I can't speak to the American system because I haven't worked in it, but I know you have. Do you
Yeah.
notice a difference there?
The biggest difference is if you ever go to the US and if you walk into a public hospital emergency room with Medicaid service, you realize that I was in New York, I remember. They're not even have enough hospital beds. People are sitting on the floor waiting to be seen.
Really?
There's not enough chairs. Obviously, this is pre-COVID times. And I think the difference is the volume and also the disparity on the people in the two system in the US is huge. But as
Yeah,
opposed to other countries, every countries have some degree of a dual system. Every country
for
does.
sure,
Even
for
us
sure.
here, if you're a
Yeah,
plastic surgeon here, you can do
yeah,
a lot of private medicine. Okay, for
no doubt.
example, like yeah,
Well, and you have a private practice as well that's
yeah,
outside of
yeah,
the public
yes.
system.
So I don't want to use the word dual because dual sometimes implies as 50-50. Like,
Mm,
but I was just saying that in Australia, where like you still have to be paying a huge tax bracket that
yeah,
supports the public system. When people are working in the private, they also have to work in public system once a week, for example. Like there's a
at a
contract.
minimum, yeah.
Yeah. So I think like end of the day, there's no perfect healthcare system is the answer.
Yeah, no, and you need to work within it. I think the reality is, and I will actually give Golden Goat Foot Cheese some credit here, because even though the US has probably the most private system that I'm aware of, certainly in developed nations, they haven't let the impoverished flounder completely. There's a process, there's a system, there's a healthcare, I guess the Affordable Healthcare Act or whatever, I guess it's the Obamacare. I mean, they've done a lot to make sure, at least to some degree, that people aren't completely left to their own resources. There is a floor there, right? Obviously, the US, they pride themselves as having no ceiling, and in a lot of ways in Canada, you and I understand this a lot. I mean, there's a lot of barriers. I mean, I could imagine. I mean, maybe this is wrong, but Tommy, would you say that as a neurologist, headache neurologist, you could earn more income in the U.S. than you could in Canada? Is that true, or am I mistaken to assume that?
It depends where you are. The U.S. is every state is also a little different, right? If you
Sure,
work in California, it's different than in Iowa or something like that.
sure,
So
sure.
I think in Canada things are quite more uniform in some ways. Okay, it's not going to be a huge
Yeah,
change disparity from province to province. Maybe Quebec is a little bit different. Like Quebec is probably the only province that stands out on its own by doing, have its own basically regulations, basically.
for
But
sure.
then as you realize going from one state to one state, it feels like a different country already in some ways.
You're saying the quality of care is even affected by
Or
some
losing the
states. Like
salary,
if you went to New York, you'd have a better care, you think, than in Iowa, as
or
that
or,
example.
or no, like salary wise, or the number of private hospitals
Gotcha,
you get
gotcha.
there. Let's say in
Right.
the Bay Area, right? Like you're going to be
Yeah,
stuck
and it's the
20
cost of
years.
living too changes so much. It's interesting because you and I are very lucky. We live in southwestern Ontario, which is one of the more affordable areas of Canada, truly, like compared to other places. And yet in the province of Ontario, certainly in our field, we get paid basically the same, right? I can't imagine doctors working and living in Toronto because the cost of living is so high there. I'm grateful that I'm here. Well, I was gonna ask one last question. I think because we've been going 40 minutes, which is pretty solid. But I do want to ask one question, and just sort of to wrap up this live stream. Was doing a fellowship worth it? Are you glad you did a headache fellowship? You're glad you're a Stanford trained, internationally published man of mystery neurologist?
Thanks. 100%.
Yeah,
I have to say the best year of my life was during my fellowship. But it's very different because I had a mission, I had a goal to go somewhere, number
yep,
one. So if there's anyone out there listening that are thinking about should I do a fellowship or not, don't just do it because you have to do it for a job. Think about like the reason behind, okay, do I want to go somewhere? Number one. So I went to California. I want to go there because I miss the sun. Because I was trained in Australia and then I was here for 5 years. And then I'm like, okay, I need to be in a place where 24/7 there's going to be sun. And two, it's that doing a fellowship, it's you already know that that's a bonus. Number two, it's
yeah,
because you're
yeah.
the certified specialist, meaning that if things don't even work out, let's say you crash
You
the
fail
course,
at a fellowship for some reason.
yeah, your fallback plan is still okay. I'll just be a general neurologist, and so the stake is not as high, but then you're just boosting your qualities, and then you meet a lot of people, and then you build your confidence. It's more like a trend, also like a partially is a transition to practice as well.
Yeah,
But I would say worth it if you check those boxes. Like you go in
yeah,
the places
yeah.
where you want, you have some goals you want to achieve. Let's say that you want to publish something that you're able to work with a certain mentors or someone
Person, yeah, that's
else,
right.
right? Then like yeah, I think there's different things. There's the work-life balance aspect that you might get out from fellowship. You realize the work-life balance is a lot more achievable actually. Like going back to your first point of
Right,
today,
right at the beginning.
the best work-life balance I've ever had in my life was through my fellowship year where I could go to the gym every day. I could go hiking on the weekend. Every weekend, I still was able to publish one article per month. I didn't have to be on call, right? Like so,
Yeah,
like I was getting paid pretty well because I was in a state that pays well, like in the
Yeah.
US. So
Yeah.
I think there's a lot of factors.
Yeah, I mean, I would say, my fellowship was a slog. Now I did a 2-year fellowship, and I did it in the same hospital where I did my residency. So it actually felt like more residency in a lot of ways, which was, not so great. But what the fellowship did do is it basically was that transition to practice for sure, without a doubt. I was doing staff call as a general surgeon. I was doing trauma. It was a 2-year, truly. If I were to say how my fellowship worked out here, was a 2-year transition to practice. At the end of the day, I polished my skills. I had mentorship. They took me to the next level for sure. And when I was done my fellowship, the one thing about being a fellow is I could take patients in the operating room independently. That's how it worked here. But because there was a staff surgeon always that had to be available, that was the rule. I had that backup, and I only had to call them in maybe once or twice over my 2 years to support me. But that was good to have that safety net, because eventually that safety net was gone, and I was taking patients to the operating room in the middle of the night on my own with no guarantee that there's anyone to help. So the fellowship was a great experience to help transition to practice in a difficult, complex academic center. But I didn't have quite the same experience as you. I didn't have quite the, I would say the demands for me were as hard. It was really more like more residency, truly.
Mhm.
And it was a different experience. But do I regret it? No, because it gave me the job that I have today, and I'm enjoying it. And you and I both know we've got a pretty good opportunity and experience here in London.
Yeah, exactly.
Well, Tommy, I'm going to say thank you for joining me on this first live stream. And I also want to say thank you to Walleye and Golden Goat Foot Cheese and Emily for your comments. It's really added to the live stream today. It was awesome. Anyway, have
Thanks.
a great night.
Have a great night, everybody.
All right. See you later.